afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on an update on influenza for the 2022 to 2023 season. My name is Andrea Saunders, and I am a communicable diseases specialist at Public Health Ontario, and I have the distinct pleasure of moderating today's session. Before we get started, I need to mention a few housekeeping items. So for today's presentation, the chat pod has been disabled to limit any distractions. We will be having a question and answer period following the presentation. So if you do have any questions that you would like to ask, please enter them in the question and answer pod at the bottom right-hand corner of your screen. And if at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. It is now my pleasure to introduce the speakers for today's presentation, Dr. Christine Navarro and Dr. Jonathan Gabay. Dr. Navarro is a public health physician with the Immunization and Vaccine Preventable Diseases team at Public Health Ontario. Before joining PHO in December 2021, Christine was an Associate Medical Officer of Health at Toronto Public Health, first working in the healthy environments and then supporting community case and contact management in TPH's COVID-19 response. Christine has a Master's of Science in Epidemiology and is also a public health and preventive medicine specialist. Dr. Gabay is a medical microbiologist at Public Health Ontario's laboratory and a pediatric infectious diseases physician. He has been the medical lead of many key programs at PHO's laboratory, including respiratory viral infections, emerging viruses, respiratory bacteria, and gastrointestinal viruses. He is appointed at the Department of Laboratory Medicine and Pathobiology and the Department of Pediatrics at the University of Toronto. Neither myself nor Dr. Navarro have any disclosures, conflicts of interest to disclose at this time. Dr. Gabay has received direct financial payments from the Global Infectious Diseases Epidemiology Online Network, or Gideon, in his role as a consultant scientific editor. For today's presentation, we hope that by the end, participants will be able to describe trends in influenza and respiratory virus activity following the many phases of the COVID-19 pandemic, both in Ontario, Canada, as well as internationally. List the influenza vaccine products that are available as part of the Ontario Universal Influenza Immunization Program, or the UIIP, for this upcoming season. Understand the use and benefits of antiviral medications for the treatment and prevention of influenza, as well as to recall the respiratory virus tests that are available at the PHO laboratory for symptomatic and asymptomatic patients. And before I hand things over to Dr. Navarro, I'm going to take some time to just quickly provide an overview of the respiratory virus season for the last couple of years, just to provide some context as we head into the next upcoming season. This figure shows the total number of influenza A cases by surveillance week for each of the last 4 influenza seasons, which for surveillance purposes start on September 1st, or week 35, which you can see at the far left of the x-axis. In the 2021 to 2022 season, which is the green line, influenza activity did not start until the late spring and actually peaked during the week of May 8th to May 14th. And this likely coincides with the easing of most public health measures for COVID-19 in the province. This is much later than what we have typically seen in the pre-pandemic influenza seasons of both 2018 to 2019 and 2019 to 2020, which can be seen in the red and yellow lines, where influenza activity began in the late fall or early winter and peaked at the end of December, early January. In addition, in the 2021 to 22 season, we saw far fewer laboratory confirmed influenza cases than in previous years, with only just under 2,000 cases were reported, compared to the approximately 13,000 to 14,000 cases that were reported in each of the 2 pre-pandemic seasons. And it's worth noting that on this figure, you cannot see the line for the 2020 to 21 season because during that season, We had virtually zero influenza activity in Ontario, with less than 30 lab-confirmed cases reported during that season. And this is also most likely the result of the public health measures that were implemented to prevent COVID-19. This next slide presents the percent positivity for other respiratory viruses other than influenza and COVID-19. And it's a very busy slide, but of note, I'll draw your attention to two lines. So in the fall and early winter of 2021, there was a sustained peak of enterorhinovirus activity, which is the light blue line at the very far left of the x-axis. This activity subsided over the winter months and started to increase again in the summer and early fall. And in fact, it continues to increase. And for the week ending September 24th, which is not visible on this particular figure, the percent positivity for enterorhinovirus in the province was 22%, making it the most common circulating respiratory virus at present. And this is compared to a percent positivity of 11% for COVID-19 and less than 1% for influenza for the same surveillance week. Of note, we also observed a sharp increase in respiratory syncytial virus, or RSV activity. And this is the gray line that you can see peaking just towards the end of December, early January. And this is much earlier and much more higher number of cases than we have seen in previous seasons. With respect to respiratory infection outbreaks in institutions, we only saw 18 influenza-related outbreaks during the 2021 to 22 season. The vast majority of our respiratory outbreaks in institutions were caused by enterorhinovirus and RSV, with a significant number of outbreaks where the pathogen was unable to be detected. When we look at what respiratory virus was happening across the country, the trends that we observed in Ontario are very similar to those reported in the rest of Canada. This figure shows the number of positive tests for respiratory viruses other than COVID-19 that were reported to the Public Health Agency of Canada by participating laboratories. As you can see towards the left of the x-axis, which corresponds to the fall and late winter, you see the increase in enterorhinovirus activity, which is the yellow bars, as well as the the yellow bars are RSV activity, which was largely driven by outbreaks in Ontario and Quebec. And the orange bars represent the enterorhinovirus activity that was circulating across many provinces. And then to the right of the x-axis, you can see a peak in late spring of the dark brown bars, and this corresponds to the late increase in influenza A activity observed across most of the country. The following two slides present the number of positive tests for respiratory viruses, the percent positivity for the 2021-2022 season in the red line, compared to the 6-year average from 2014 onwards in the dotted lines. And as you can see, as previously discussed, the influenza A activity peaked much later in the year than in previous respiratory virus seasons. And we had very little, if any, influenza B activity. We did see that early peak in RSV cases in the early fall and late winter, as well as enterovirus activity that did follow a similar trend as in previous seasons. We also saw an increase in human parainfluenza virus compared to previous seasons, and a late start to the human metapneumovirus circulation towards the end of spring and early summer across most of the country. So now let's look at what was happening internationally with respect to influenza. So this slide represents the total number of influenza virus detections that were reported to the World Health Organization for the 2021-22 season by subtype. And as you can see towards the left of the x-axis, there was a peak in influenza activity in the late fall and early winter across many countries in the Northern Hemisphere, including the United States, Western and Eastern Europe, as well as the Western Pacific countries. And this may relate to variations in the implementation of COVID-19 prevention measures across many of those countries. And it's worth noting that in the Western Pacific region, which includes China, Japan, South Korea, and the Philippines, influenza activity was almost exclusively caused by influenza B strains. The much larger peak towards the right of the x-axis corresponds to both the late start to the influenza season in many other Northern Hemisphere countries, including Canada, which also overlaps with a much earlier than expected start to the influenza season in the Southern Hemisphere, particularly in Australia. The influenza season in Australia, or most of the Southern Hemisphere, typically runs from June to September, and is often predictive of subsequent influenza activity in the Northern Hemisphere for the following season. In 2022, which is the red line, Australia recorded its worst influenza season in over 5 years, with activity starting in late April and peaking in early June, which is approximately 2 months earlier than normally seen, and with a massive surge in cases that was more than 5 times higher than the average for the previous 5 seasons. And that average can be seen in the yellow line. So you can see a much earlier start to the season and a much higher burden of illness in the country. This surge in cases is thought to be the result of decreased immunity, both natural and acquired, to influenza in the population, resulting in an increase in the number of susceptible individuals. In the 2022 influenza season in Australia, almost all of their influenza activity was caused by influenza A viruses. However, the vast majority were not further subtyped. And in this figure, you can see the rate of influenza activity per 100,000 population by age group. And in this figure, we can see that the highest burden of influenza activity was actually experienced by the younger population. So those under 15 with the highest rates, with rates decreasing with increasing age. So what does this mean for us in Ontario? So as you saw from the previous slides, there were 3 activities that were most noted. So we had a much later start to the influenza season than in previous years, with far fewer cases than have been reported in previous pre-pandemic seasons. We saw an early increase in enterorhinovirus activity, which has persisted into this fall and early winter with very high % positivity. And we saw an increase in RSV activity that peaked in the early fall and winter, which was far earlier than we've seen in previous years. Some countries, including those in the Northern Hemisphere, did report epidemics or higher detections of influenza activity than in previous seasons. However, there's insufficient data available to determine influenza vaccine effectiveness for the 2021-22 season. So we know that some viruses other than SARS-CoV-2, or the virus causing COVID-19, are already occurring and expected to continue. As I've mentioned already, we have an enterorhinovirus activity at the moment of 22%, so it's by far the most common circulating respiratory virus at the moment. The widespread public health measures, including masking, physical distancing, and capacity limits that reduce the impact of COVID-19 and other respiratory viruses, have been lifted across Ontario. So this may also facilitate the spread or transmission of other respiratory viruses. And we have a reduced population immunity from both lack of exposure over 2021 and 2022, as well as some vaccine fatigue, which may increase circulation and severity in the upcoming season, particularly amongst young children who are at higher susceptibility and indicating a higher need for influenza vaccination in this population. And so with that, I will turn it over to Dr. Navarro.
Thank you, Andrea. I'll be talking now about the flu vaccines for the 2022-2023 season. So influenza in humans is caused by 2 main types of influenza virus. Type A, which is classified into subtypes based on their surface proteins, hemagglutinin and neuraminidase, or H and N that you see in their strain names, and type B, which consists of two antigenically distinct lineages, B. victoria and B. yamagata. Seasonal influenza vaccines are either trivalent or quadrivalent formulations. The trivalent vaccines contain 2 influenza A and 1 influenza B strain. The quadrivalent influenza vaccines contain the 3 strains included in the trivalent, plus an additional influenza B strain. The World Health Organization makes recommendations for the flu strains contained in the flu vaccine for the Northern Hemisphere every year in February. This year, their statement was based on the influenza viruses that were in circulation since September 2021, which Andrea has nicely described. The composition of the influenza vaccines that we have here in Ontario is shown in the table. The Victoria H1N1 strain used in last year's vaccine was maintained for the 2022-23 season based on the few H1N1 viruses that were identified since last September. As mentioned earlier, most of the subtype specimens were influenza A H3. However, lab studies showed that the circulating strain was not recognized well by antibodies generated against the Cambodia strain in last year's vaccine. So this was actually changed to the H3N2 Darwin strain for this year's vaccine. All of the influenza B viruses collected since September were of the B Victoria lineage. But lab studies again showed that most of these are recognized poorly by antibodies generated against the 2021 Washington strain of the Victoria lineage that was used in last year's vaccine. So this was also changed this time to the Austrian strain of the Victorian lineage for this coming season. And while no viruses of the B Yamagata lineage have been detected actually since March 2020, the Phuket strain of the Yamagata lineage was maintained for inclusion in quadrivalent vaccines for this coming season. The National Advisory Committee on Immunization, or NACI, makes its recommendations on influenza products authorized by Health Canada in the late spring, based on the WHO statement and current scientific evidence, with consideration of the epidemiology of influenza in Canada. As an overarching statement, NACI does recommend that influenza vaccines should be offered annually to anyone 6 months of age and older without contraindications. Ontario's Universal Influenza Immunization Program, or UIIP, offers vaccine for all persons 6 months and older with available products shown by age group in the table. For the 2022-23 season, all UIIP products are egg-based vaccine. So the mammalian cell culture-based vaccine, the recombinant vaccine, and the live attenuated influenza vaccines that are approved in Canada are not currently part of the flu program for this year. The standard dose quadrivalent vaccines, Flu-Laval Tetra and Flu-Zone Quadrivalent, are available for all age groups 6 months and older. For children and youth 6 months to 17 years of age, the quadrivalent vaccines are recommended given the burden of influenza B in this age group seen in the pre-pandemic era, and the potential for lineage mismatch between the predominant circulating strain of influenza B and the single B strain that's usually found in the trivalent vaccine. The standard dose quadrivalent inactivated vaccines are the only ones available this flu season for the youngest in this age group from 6 months to 4 years. For those 5 years to 64 years, there's a third quadrivalent vaccine, Afluria Tetra, that's available. For older persons 65 and older, there are 3 standard dose quadrivalent vaccines. As well, there's also Flu-Zone, which is a high dose inactivated quadrivalent vaccine, and Fluad, which is an adjuvanted trivalent vaccine. I'll go into a bit more detail on those for the next couple of slides. And we want to focus on older adults because, in addition to the increased complexity associated with having multiple vaccines for this age group, they also bear the greatest burden related to influenza. In pre-pandemic times, this was estimated at 1/2 to 2/3 of hospital admissions and almost 90% of deaths related to influenza. Older adults also tend to demonstrate lower initial immune responses to influenza vaccine, and they've generally had lower estimates of vaccine effectiveness compared to adults under 65 years of age, hence the need for more effective vaccines in this age group. QIV, or quadrivalent inactivated vaccine, is in the leftmost column. This is a standard dose inactivated vaccine that's available for everyone 6 months and older. Pre-licensure studies generally have indicated similar immunogenicity against all strains and similar safety profile of the quadrivalent vaccines when compared to their trivalent counterparts. And of course, as you'd expect, they also have superior immune response and protection against that second B strain. In the middle column, we have the high-dose quadrivalent inactivated vaccine, or HD-QIV. Fluzone high dose, or Fluzone HD, has been authorized since 2016. It contains 4 times the standard dose of the hemagglutinin for all 4 strains in the standard dose. Studies in older adults have shown that higher doses induce better immune responses than the standard dose quadrivalent inactivated vaccine, especially for the influenza A strains. As well, there is, of course, the added benefit of that second B strain. There's also good evidence from earlier studies that the high-dose inactivated vaccine provided superior protection compared with the standard dose, specifically for influenza-like illness, influenza-related deaths, and all-cause hospitalization. The higher dose vaccine has been seen to be related to higher systemic reactions, including malaise, myalgia, and fever, but these tend to be mild and transient and resolving in less than 7 days. Then in the rightmost column, we have the adjuvanted trivalent inactivated vaccine, or TIV ADJ. The FluAd is a standard dose vaccine containing the adjuvant MF59. It's authorized in Canada in 2011. Overall, though, there are fewer studies of this particular vaccine than there are for the high-dose quadrivalent influenza vaccine. But in a review conducted by NACI in 2018, they did find fair evidence that the adjuvanted TIV can reduce the risk of hospitalization for influenza and related complications compared to being unvaccinated. At that time, there was insufficient evidence that the adjuvanted TIV induces better immune responses or is more effective than the standard dose unadjuvanted trivalent. RCTs do indicate higher risk of injection site reactions, including pain, redness, and induration, following the adjuvanted TIV when compared with non-adjuvanted TIV. Finally, there is limited evidence comparing high-dose QIV directly with the adjuvanted TIV on any of the possible benefits and harms to inform a recommendation of one over the other at this time. Therefore, NACI only has one preferential recommendation for individual decision-making for 2022-23 for adults 65 and older. And that is, when available, high-dose QIV should be used over standard dose QIV. And this is based on the evidence of better protection than the standard dose in the burden of influenza A, H3N2 in this age group. As you can see from the bottom right of the graph, influenza A made up 79% of typed influenza in persons 65 and older, and of these, 86% were H3N2, which is actually a much higher proportion than for any of the other age groups shown here. For individual and public health program level decision-making, any of the available age-appropriate influenza vaccines should be used. And this is important to emphasize when an older person presents for vaccination in order to avoid delays in vaccine uptake and to maximize coverage in a timely way, especially in a high severity season that can have a higher and earlier peak, which is what we saw in Australia. So it remains to be very important to be vaccinated this influenza season, especially for persons 65 and older. Continues to be the most effective way to prevent influenza illness and related complications, especially in the context of reduced immunity to influenza and the ongoing circulation of COVID-19 virus. Vaccination is going to be an important component this year for managing healthcare system capacity during this coming season. And that's true whether you're a healthcare worker or a member of the public. One way to increase vaccine uptake is to remember that other healthcare visits can be opportunities to offer the vaccine, not just routine visits. So if a patient is coming to see you for a check-in for their diabetes, But also, if you are able to co-administer influenza vaccine, you can do that with COVID-19 vaccine and other routine vaccines like pneumococcal vaccine. So just a few words about co-administration. So it can be given at the same time or any time before or after other vaccines, with a couple of caveats that I'll discuss on the next slide. And when 2 or more vaccines are given at the same appointment, you should use separate limbs or separate them. You're injecting into the same muscle, separate them by at least 2.5 centimeters. And of course, use a different needle or syringe for each vaccine. So when it comes to co-administration with COVID-19 vaccines, the recommendations have evolved over time. With the rollout of COVID-19 vaccines in December 2020, NACI started cautiously recommending against simultaneous administration of COVID-19 vaccines with any other vaccines for adults. And that was to minimize potential risks and erroneous attribution of an APHE to a particular vaccine. As more was learned through surveillance of adverse events following immunization and a few studies of co-administration of COVID-19 and influenza vaccines, which showed no evidence of immune interference, they did change this recommendation to allow for co-administration at any time before or after other vaccines. First, they did this for adults, and then they extended that recommendation to adolescents ages 12 and older. Now, if you look at the current influenza statement, it does include this recommendation for co-administration, but even since the release of that influenza statement, NACI updated its COVID-19 vaccine recommendations to allow for co-administration as well for persons 5 years and older. So now it's only for persons who are 6 months to 5 years of age that Moderna Spikevax should not routinely be given concurrently with any other vaccines, including influenza vaccine. It's advised to wait 14 days before or after Spikevax before giving other vaccines. Again, this is really more precautionary as more is learned about COVID-19 vaccines in this younger population and to prevent that erroneous attribution of APHEs. And so this recommendation may change in the future. Now, the Shingrix vaccine is a publicly funded vaccine in Ontario for older adults. And while the co-administration of Shingrix with non-adjuvanted standard dose inactivated vaccines has shown no evidence of decreased immunogenicity or any concerns with safety, there currently aren't any data on the co-administration of Shingrix with adjuvanted or high-dose influenza vaccine. In particular, it's uncertain how adjuvants in the 2 vaccines may interact, and an ideal period of time between the vaccines, if given sequentially, has not been determined. So you may prefer to give your patient an unadjuvanted influenza vaccine if they are also to receive Shingrix. And the next slide just contains some handy references for you. And then next, I'll be speaking about the use of influenza antiviral medications for the treatment of individuals. So the antivirals that are available in Canada are neuraminidase inhibitors. These bind the neuraminidase active site on the influenza virus, and it blocks the release of new virus particles from host cells that are infected. So this prevents further replication and spread of the virus. They can be used for treatment of individuals with moderate or severe illness or who are at risk of complications for influenza, as well as for treatment and prophylaxis and outbreaks. It should be offered as soon as possible. It's best done within the first 12 hours, can be up to 48 hours or even beyond that, especially if a person has progressive, severe, complicated illness or those at high risk of complications. This table describes the 2 antiviral medications that are available for use in Canada. Oseltamivir or Tamiflu is the primary agent for the treatment of suspected or confirmed influenza. It's available as a capsule or a liquid suspension for children, and it's readily absorbed through the gastrointestinal tract. The usual dose for persons 13 and older is 75 milligrams daily, but there's an excellent document from AMI from 2019, the foundation document for the use of antivirals, that provides the dosing adjustments for children under 12 and for those with known renal impairment. It's not approved for routine treatment of seasonal influenza illness in children less than a year, but it can be considered on a case-by-case basis. Zanamivir or Relenza is a dry powder that's inhaled to deliver the drug directly to the respiratory tract. Treatment with zanamivir is for persons 7 years and older, should be considered for persons not responding to oseltamivir therapy, those who have developed influenza while receiving oseltamivir prophylaxis, or those in whom influenza B infection is confirmed or strongly suspected. It's generally not recommended for long-term care home residents, and they may have difficulty using the inhaler. In high-risk patients with seasonal influenza, both antivirals may reduce hospitalization, and studies have shown that oseltamivir in particular may reduce mortality. I also wanted to point out that since the 2009 H1N1 pandemic, including last year's flu season, nearly all circulating strains have been sensitive to both antivirals. So if you're considering treating somebody for influenza using an antiviral, there are 3 questions you can ask yourself. Is influenza circulating in your community? Does your patient have symptoms compatible with influenza? Is your patient at high risk for complications, or do they already have moderate, progressive, severe, or complicated influenza, which includes but it's not limited to those who are hospitalized? So the first question is influenza circulating in your community? And we have a couple of reports on our webpage where you can use to refer to that information. Your public health unit will also have this information most likely on their website as well. On our website, we have the laboratory-based respiratory pathogen surveillance report on the left, and then on the right, there's the interactive Ontario respiratory pathogen bulletin, and you just have to, for this map, you just roll over your health unit and it will tell you if the activity is, say, sporadic or localized or widespread. Next question is, does your patient have symptoms compatible with influenza? And I recognize that it's going to be difficult to anticipate what we might see this coming season. And it might be difficult to differentiate between influenza and SARS-CoV-2 infection if both viruses are co-circulating. So this PHO document published last fall is a handy guide to the key features that may help you answer this question. Testing may also help to guide management, but the clinical utility in particular of rapid point of care testing continues to evolve. And as we discussed earlier, lab confirmation of influenza is not required before initiating treatment of an individual with influenza antiviral. Given the low circulation of influenza during the pandemic so far, co-infection has not been commonly reported, but it may occur. Patients with both influenza and SARS-CoV-2 co-infection who are receiving COVID-19 antivirals can also receive oseltamivir, although whether there are significant drug-drug reactions or interactions is not yet known. And then the last question is, is your patient at high risk for complications of influenza? And this is really going to influence your decision as to whether or not a person should be receiving this as early treatment. The risk factors are listed here. So residents of nursing homes or other chronic care facilities, older adults, those with underlying medical conditions, persons who are pregnant or up to 4 weeks postpartum, Indigenous peoples. And although children under 5 years or age under 5 years is a risk factor for complications, antivirals aren't routinely recommended, but it can be considered for this age group. And again, we have a few more references for you to go to should you have further questions about some of these antivirals. And next, I will turn it over to Dr. Goubet.
Thank you, Christine. Good afternoon, everyone. So I'm just going to talk about influenza and respiratory virus testing at Public Health Ontario's lab for this upcoming season. The overarching message is that we're actually using the same testing algorithm as we did last year, for those that were familiar with that, but I'll definitely be going over it again now. Just to start off, recapping on what the different respiratory virus tests we currently have at PHO laboratory. So we have a standalone SARS-CoV-2 PCR. We have an assay that would coined with the term fluvid, and that has influenza A, influenza B, SARS-CoV-2, and RSV in it. And then we have the broader multiplex respiratory viral PCR, and that one is the broad panel that I won't read out all the names, but that's the one that has a large number of targets. That's our largest respiratory panel. Just a few points on there. It does detect both RSV A and B and parainfluenza 1 to 4 and the 4 seasonal human coronaviruses, but just does not differentiate between them. So the results would say RSV, coronavirus, parainfluenza, but not name the individual ones. And the human coronavirus in that assay does not cross-react with SARS-CoV-2. The most recent change was really a while ago, and that was in July last year. We added offering testing for children, basically anybody under the age of 18, seen in an emergency department with acute respiratory symptoms, and they could be tested by the MRVP, the expanded panel. And this was really done to help with providing the province with additional respiratory virus surveillance in that age group, and just to reinforce that we don't feel that it's required for clinical testing, but it can be ordered, and that helps the province get additional surveillance data. And we are continuing that availability as we move into winter. So going through the different patient settings, what I would want to point out is that even though we have this assay called fluvid, that was the influenza A, B, RSV, and COVID, anybody who actually meets criteria for the seasonal respiratory virus testing, set apart from COVID only testing, they will actually be tested by the MRVP, the expanded panel. The fluvid is done at some of our public health lab locations that don't have the expanded MRVP assay, and that's a way of getting quicker information about influenza in addition to COVID. And then those samples will be sent on to one of our MRVP testing sites to have the expanded panel done subsequently. So there's no like certain patients only get fluvid while others get MRVP. They will all end up getting the MRVP. So for hospitalized patients, they're basically eligible to have that. And then we continue to offer the MRVP for people in remote communities. In addition, we test people in institutions with sporadic acute respiratory illness. So that could be long-term care homes, correctional facilities, other congregate settings such as shelters, and they will be eligible for the expanded MRVP. And then for outbreaks, we would test up to 4 specimens by the expanded MRVP. And depending on the local approach, any specimens that are submitted can be tested, can have SARS-CoV-2 ordered on them. That is not limited. And then we do have an open door policy. We're happy to be contacted if you have submitted 4 specimens for a particular outbreak and it seems to be carrying on longer than expected, or there's more patients affected than expected. You can contact our team and request to have an additional set of samples tested. Usually it would be an additional 4, say, but we're open to discuss, say if there's an outbreak with both SARS-CoV-2 and influenza, we are open to discuss what amount of additional testing would be done on the additional patients to help sort out who has flu and who has COVID. And as you're probably all aware, for asymptomatic patients, we continue to only offer SARS-CoV-2 when those are collected. What's important is that we do need the right test ordered, and the patient setting really needs to be clearly marked on the requisition, because it is that patient setting that dictates what test is queued up for that sample. And then also for outbreaks or investigation, we need the assigned outbreak, or if there's an investigation number, to have that included on the requisition. And here's just a few quick screenshots, reminding you, we did develop this requisition. It's now a couple of years ago. We have a dedicated COVID-19 and respiratory virus test requisition. So that's the preferred requisition for both SARS-CoV-2 and seasonal respiratory virus testing. And here's just a blow up of the box where we ask you to clearly identify the patient setting. If there is no patient setting identified, unfortunately, we'll only be able to offer SARS-CoV-2 testing. And then we try to, we have a box, sorry, for the, as I said, for the clinical symptoms, just the key ones to be marked out for us. And we have 3 choices. Either you can ask for SARS-CoV-2 alone, the seasonal respiratory viruses, or both. We can accept saliva for SARS-CoV-2 testing. However, we can't perform the seasonal respiratory virus testing, so just be aware of that if electing to submit saliva. And again, just highlighting here the area to mark investigation numbers just below the patient identifiers. This is what I mentioned before, that you can consult us if you feel that testing more than 4 symptomatic patients is warranted. Of course, we ask that you wait to see what comes back on the first round of testing before you entertain doing further testing, but we're definitely open to having that discussion, and that can be done by contacting our incident and outbreak response team or contacting our customer service line. If you are ordering sort of other respiratory pathogen testing, such as mycoplasma, chlamydophila, then we do ask that you use the general test requisition for those orders, but they can be added to the same samples. And just a reminder that all of this information is included in our test information sheet, including which of our different locations perform which tests, if it's flu versus MRVP. I also want to highlight that we do continue to offer testing for novel influenzas for those with risk factors for those, and antiviral resistance, say for patients who are immunocompromised with ongoing positive tests, or people who have positive tests after receiving antiviral prophylaxis against influenza. We also offer testing for MERS-CoV when indicated, and enterovirus D68. On that point, the United States put out an alert that they were seeing some enterovirus D68 activity, and PHO laboratory has started doing some surveillance. We've gone back to early August, and we are actually seeing a wave of EVD68 in Ontario at this time. Approximately 50% of our enterovirus positive samples are coming back positive for enterovirus D68. Further information is available at our test information index. If you look up enterovirus or enterovirus D68, you can see how to order testing at our laboratory for that if wanting to submit samples, particularly for that screening. So we have a lot of people to acknowledge. Sorry, this thing's jumping. A lot of people to acknowledge, definitely all the public health units for their collaboration in dealing with our approach to respiratory virus pathogens over the last years, our ministry, Ontario's Ministry of Health, within Public Health Ontario, our Health Protection and Emergency Preparedness teams, and PHO laboratory. So I'll now hand back to Andrea to carry on.
Okay, thank you very much, Christine and Jonathan, for a very informative presentation. We do have some time now to address any questions that you may have. We have already received a few in our chat box, but if you do have any questions you would like to pose to our panelists, please enter them now in the Q&A pod, and we'll do our best to get to as many as we can in the next 10 minutes or so. So we have received a few questions already, and one of the first questions has to do with the respiratory trends that I described earlier in the presentation. So given that one of the theories we have as to why influenza activity was reduced in the past couple of seasons is the implementation of COVID-19 measures, what may be some of the reasons that we saw such an increase in RSV and rhinoenterovirus during the past season in particular? So I can start provide some of my own perspectives and then turn things over to Jonathan and Christine to see if they have anything else to add. But for RSV in particular, we know that the majority of cases are often seen in young children who may not be the best at applying public health measures like hand washing and distancing, etc. And the remainder of our RSV, we saw a lot of activity in our long-term care homes, which, given the number of outbreaks we've seen during the COVID-19 pandemic and how disproportionately the long-term care home population has been burdened by COVID-19, we know that there are some challenges and potential barriers in the application of COVID-19 measures in those settings. So that might partly contribute to why we've seen so much RSV activity. And with enterorhinovirus, compared to COVID-19 and influenza, this virus is often milder. A lot of people will have this virus and not necessarily present symptoms or have very mild symptoms, which may contribute to individuals still going out and maybe not masking when they should be, or going out to events or family gatherings, et cetera, when they are in fact sick, but may not be aware of it. So that's what I think may be going on. But if Jonathan or Christine have anything else they'd like to add, feel free to jump in.
I think I generally agree with what you've said. I think we're still learning about what has changed the seasonality of the different viruses, but I think there is that large component of all the IPAC measures, but I don't think it's just that. Like I think somebody posted why the flu was barely there, yet we had waves of RSV and rhinovirus. So I don't think we totally understand yet, but obviously each virus is a little bit different in the way it's able to sort of return. It looks like rhinovirus has been less affected, at least in the last year in terms of its seasonality, whereas RSV got shifted and influenza has been shifted. So I think there's still many unanswered questions. And I think it's more than just IPAC measures.
Mm-hmm.
But hopefully we'll learn more. I was always in shock during the 2009 pandemic when the seasonal H1N1 virtually disappeared over a period of 2 or 3 weeks as that pandemic H1N1 arose. It's like the viruses are talking to each other. So I think, there's some interaction going on, but I don't think we understand all of what's going on exactly yet.
Okay, thanks, Jonathan. So the next couple of questions are for Christine. So are there any recommendations on co-administration of influenza vaccine with Imvimune for monkeypox?
Yeah, for Imvimune, which is the vaccine that's used to prevent monkeypox and smallpox, there is only one caution regarding co-administration for that vaccine, and that's with mRNA vaccine. So with there is a recommended waiting period of 4 weeks before or after an mRNA vaccine for COVID-19 with Imvimune, but not for influenza. And I'll just take a second to explain as everyone is probably aware, following mRNA vaccine, there is the rare risk of myocarditis, pericarditis. Of course, or what we've seen with a small number of studies following Imvimune vaccine, there are some indications of cardiac adverse events following immunization, but that's more in like a rapid heart rate or abnormal ECG findings. So as they still continue to find out more information about monkeypox vaccine, they may again decide to change this recommendation and no longer have a caution against concurrent administration with the mRNA COVID-19 vaccine.
Okay, thank you. And the next question You mentioned a lot about the use of antivirals, including Tamiflu and Relenza for treatment of influenza. But do you have any recommendations on populations or situations when antivirals should be used for prophylaxis?
Yeah, so it can be used as prophylaxis, say in an institutional setting. So of course you will be treating residents who have suspect or confirmed influenza, regardless of their immunization status. You can also use prophylaxis of the residents who are not ill with any influenza symptoms who are located in the outbreak area, and that's regardless of their immunization status. Prophylaxis can also be offered to unvaccinated staff members. And then I think there may have been a question about mismatch. That's another part where prophylaxis may be required. So staff members who are vaccinated, but there is a mismatch between the vaccine and circulating influenza strains. If you consult with your public health unit, that'll help you make a decision about whether to offer prophylaxis to those individuals.
Okay, thank you. So again, another question about vaccine. You are a popular lady today, Christine. Do you have any comments on the uptake, what we anticipate the uptake of the flu vaccine might be this year, knowing that there's a lot of vaccine fatigue with the rounds of COVID vaccines over the last few years? Do you anticipate that there will be a lower than average uptake of flu vaccine, and what, if any, recommendations would you have for trying to increase speaking to people who may be hesitant about getting vaccinated for flu this year?
Yeah, thanks, Andrea. There have been some surveys occurring during the pandemic asking people about their uptake of influenza vaccine. In the Canadian longitudinal study on aging, they did find that older adults during the 2020-2021 season did have a higher uptake. And this is, sorry, I should mention this is for adults 50 and older. They did have a higher than usual uptake of self-reported influenza vaccine. In studies of like general adult populations, however, they have not really seen that same change in the seasonal influenza vaccination coverage survey of Canadians for 2021-2022. They didn't really see an increase. It was actually a tiny bit of a decrease for adults 18 to 64, even among those who have chronic conditions. And for those who are 65 and older, it was about the same. We don't really have the same data for children, but we do know that from the adult populations, a lot of people think that they aren't at risk of getting influenza. A few people, maybe about a third, actually believe that they were at risk of getting flu from the influenza vaccine. So, you know, with vaccine hesitancy in general, there are many different reasons why a person may be hesitant about receiving it, and it's really about trying to understand that individual's reason for not being vaccinated. So you're probably, many of you are probably aware of the C's related to vaccine hesitancy, so confidence, complacency, convenience. There's a couple of other C's, including calculation, so how much they've looked at the evidence online and how they're weighing their risks and benefits, and then collective responsibility. Now, I'm going to put into the chat an excellent primer. It says it's related to COVID-19 vaccine, but it is really relevant to all types of vaccines, and it will help you have conversations with your individual patients to address, try to elicit their reasons for not getting vaccinated and to address some of those reasons.
Thanks, Christine. And with respect to residents of long-term care homes, do you know what the recommendations are for timelines for administering flu vaccine?
That would be perhaps a better question for the Ministry of Health as they're responsible for distributing the vaccine. For long-term care home residents, we do of course want them to be prioritized. They'll be getting the vaccine. They should be vaccinated as early as possible in the season, because as you mentioned, with Australia, it was a peak that was higher and earlier than what was anticipated. So as soon as that influenza vaccine is available to you in your health unit, I would recommend that the residents, and if you can, the staff as well, get vaccinated as soon as possible this year.
Thank you. And I just wanted to go back to a question that was asked a little bit earlier that you've provided a response to already, but someone asked about whether antivirals for COVID, so Paxlovid, and antivirals for flu can be administered at the same time. And the answer is yes, but as long as a person meets the criteria for receiving both, they can be administered at the same time. However, limited information is available at the moment on drug-drug interactions. And there is an Ontario Science Advisory Table guidance document on Paxlovid that may answer some additional questions you might have about that particular antiviral. So there is one additional question around influenza vaccine for children under 9 years of age. And if they have not had a flu shot previously, what is the recommendation on the number and timing of doses?
Yeah, what you've typed there is correct. So 9 and under, 6 months to 9 years would get, if it's their first time getting influenza vaccine, then they'll have they should have 2 doses, 28 days apart. If they've received it in a previous season, even if they're under 9, then that single dose for that or this season is sufficient.
Okay, thank you. And with that, we are just about out of time. So as we wrap up today's PHO round session, I would like to extend a sincere thanks to Dr. Christine Navarro and Dr. Jonathan Gabay for presenting. And I would also like to thank all of you, all of the participants who joined us for today's session. You can expect to receive a brief and anonymous round survey for today's session, and we ask that you please try to complete this to help us improve our future programming. Lastly, to access past PHO rounds presentations and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. And just before I let you all go, I just wanted to also flag that we do have a new respiratory virus product that PHO will be publishing weekly for this upcoming season. It's called the Respiratory Virus Overview in Ontario, and it combines indicators on influenza and COVID-19 activity. So if you take a look on our PHO website and give that a search, you can see that going forward. Very informative report that we hope you will find useful. And with that, I would like to, again, thank you all for participating and enjoy the rest of your day.